Hello, everyone. Good morning. Hopefully, everything is working okay. Trying to get us all set up for a good free webinar this morning. How is everyone doing? I am really glad you're here. I'm really glad I get to teach today about one of my all-time favorite things, congenital heart defects. So before we jump in to our webinar, I just want to know where everyone in this world is coming from. I am broadcasting today from North Carolina. If you would like, we can kind of interact and talk to each other today using Slido. You can pull out your phone and just scan this QR code or go to slido.com and use the code CHD and let me know, where are you coming from today? I know in some areas we're having some bad weather. We've got hurricane season going on. Hopefully everybody is safe. All right. We've got some people from the Philippines. We've got Florida. So you're definitely getting that weather. Canada, Michigan. All right. Someone else from North Carolina. Good to see you. I have a very rainy day here in central North Carolina, so hopefully you have better weather than me. All right, amazing. I love to see it. Well, let me tell you just very briefly what you can kind of expect from this Archer free webinar. You know we do these every Monday, Wednesday, and Friday. Today, we're getting you all the content about congenital heart disease. I know it's kind of a tricky subject. It's maybe not something you dove really deep to in nursing school, and then you start getting NCLEX questions about it, and that's a little stressful. So we're going to make sure you know what you need to know for the NCLEX. As you just saw, we're going to use Slido so we can actually interact and hang out. I'm going to ask you questions, give you quiz questions. The faster you answer and the more answers you get correct, the higher you will go on the leaderboard. And at the end, we'll be able to see who came out on top. Whoever does come out on top will be the winner. They're going to win 2 free private tutoring sessions with any tutor of your choice. Those are valued at $75 each, so it's a whole $150 prize. You'll be able to keep one of those and give one to your best nurse friend. I always say there's no friend like a nurse friend, so what better thing to share than some tutoring? Anyone have any questions about how this whole Archer free webinar shebang works? All right, looking good, looking good. Perfect. Well, let's go ahead and dive right in. And before I just start talking to you about heart defects, we need to touch on how the heart actually develops. Because the way blood flows through a baby's heart when they're inside of mom is super different than the way blood flows after you're born. So we call it fetal circulation and then newborn circulation. The overarching reason for this is that when baby is still inside of mom, they don't need for their lungs to expand and get oxygen. They're floating around in amniotic fluid. Those lungs, they're not doing anything. They get all their oxygen from mom. So it would be a little bit of a waste for us to send a bunch of blood to the lungs. Therefore, we kind of skip them. We kind of go right around, don't send blood to the lungs. Instead, just go ahead and send it where it needs to go, out to the body. Now, in order to skip the lungs, we have a few holes in the heart. There are 3 of them. The foramen ovale, that's the first one we're going to talk about here. Let me make sure my pen is on so I can show you guys right where it is. You see where that white arrow is? It's a little hole between the right and the left atria. So blood is able to shunt. When I say shunt, I mean move across the left atria over to the right atria so that it doesn't bother going to the lungs. The next place we have a hole is between the pulmonary artery right here and the aorta right here. So again, where you see these white arrows, this time this hole is called the ductus arteriosus. Again, blood should be leaving that pulmonary artery outside of newborn circulation. It's going to go to the lungs. We don't want that. So it goes over that hole out the aorta and gets to the body. Okay, I know that seems kind of basic, but those two concepts and knowing where those holes are, I promise they are really going to end up helping you. So let's check that you actually know them. Again, scan that QR code or head over to slido.com, join with the code CHD, and let's do our first quiz question. What does the foramen ovale allow? Does it allow blood to go between pulmonary artery and aorta, between the atria, between the ventricles, or between the pulmonary veins and the superior vena cava? Okay, very good. 71% of you got it. It's that hole that allows blood to shunt or move between the atria. So first up on our leaderboard, getting it correct in 8 seconds was Mia. Nice job. We have got 10 questions today, so 9 more chances to get up on that leaderboard and win some private tutoring. Okay, now that we got the boring stuff out of the way, we looked at exactly where those holes are in fetal circulation. Let's go into the actual defect. CHD, congenital heart defect. The defect just means there's some sort of abnormality, okay? The heart didn't structurally form quite like we wanted it to. There could be holes, there could be areas that are too big, too small, too stiff. And we use a lot of different words to talk about those defects or those changes. The first word we might use is stenosis. That's when something is stiff or thick and it's hard for blood to flow through it. Atresia, or if something is atretic, means that it didn't develop. It's not there. Or maybe it was underdeveloped. We call that hypoplastic. If it's overdeveloped, then that'll be hyperplastic or hyperplasia. Another term you'll hear is coarctation, when we have a narrowing or a stricture of something. Usually this is the aorta. Then the next set of words we will use are about how the blood flows depending on those abnormalities in the heart. And remember, when I talk about blood moving from one area to the other, I use the word shunting. For blood to shunt or move across an opening, it will always go in the direction of high pressure to low pressure. I always say blood is kind of lazy, just like me. I'm not running uphill if I have a downhill choice. Am I right? Like I'm if I see a hill going up, a hill going down, I'm gonna go down. And so will blood. Naturally, our left ventricle has higher pressure because it's bigger for sending that blood out to the body. So if I get a hole between my right and left ventricle and blood is going to shunt or move, it's going to go high to low, left to right, okay? Now, in a left to right shunt, if I have a shunt, that's the one that I want, okay? Because naturally, the blood on the left side has oxygen. It just came back from the lungs. The blood on the right side is that deoxygenated blue blood. So if I go from high to low pressure, left to right, my oxygenated blood goes over to the right side, then that means I get some extra blood flow going to my lungs. The fancy word for that is pulmonary overcirculation, because too much blood goes to the lungs. But it's all oxygenated. I'm not getting any blue blood out to the body. There is no cyanosis. So these types of defects are what we call acyanotic. No cyanosis, pink baby. That's why if I have a shunt, that's the one I want. If something changes in my anatomy, though, and it makes the pressure on the right side higher, I'm still going to go from high to low pressure, so it will cause a right to left shunt. I do not want this because then deoxygenated blood from the right goes to the left, gets picked up by the aorta, and goes out to the body. Blue blood going out to the body causes cyanosis, so our right to left shunts, those are our cyanotic defects. These are kind of the two big groups that we throw all of these CHDs into. Cyanotic, they've got the right to left shunt, or acyanotic. You've got that left to right shunt, okay? We've also got some that are a little unique where they're obstructive, they stop blood from going out, or there's something called ductal dependent, and we'll hit on that later. But first, I just want to check your knowledge again, because that was a lot of stuff. I said a lot of words, and it's kind of hard. It's early, at least for me. So pull out your Slido again, get ready, and I want to know if you picked up on these terms. Which of the following indicates a stiff or thick area? Atresia, coarctation, shunting, or stenosis. You got to know these words. All right, we got a smart group on this morning. Yes, if it is stenosed, it is thick or stiff. Let's check our leaderboard. We've got Claire at number 1, still 8 more questions to go. So I'll pause here and I want to know from you guys. You can just pop in the chat, Facebook, YouTube, wherever. Do you guys already have the SurePass program? Are you in intense prep? What are you using to study for your NCLEX right now? What do you guys already have? Okay, let me pull up my chat here. Good. Okay, so some of you do have SurePass. Chanel's got it. Okay, perfect. So if you don't have a program yet, SurePass is your comprehensive program for passing the NCLEX, okay? It bundles everything at Archer Review together. So I can already tell you, after just 1 hour of us talking about CHDs, it's not going to be enough. You guys are going to be like, that was a lot. I can't remember this. I need to watch this again. SurePass is how you do that, okay? It's got the QBank. It's got on-demand videos, including pediatrics that go through your heart defects. It has daily live lectures and a comprehensive 3-day live review. So it's meant to be used for about 6 months as you get ready to study for your NCLEX. You can go all the way through the program, and it has a 99% pass rate. So I'm really glad to see a lot of you already have that. That means after this lecture today, if you're like, hold the phone, Morgan, this was a lot, you can go back into your on-demand lectures. You've already got access. For anyone who doesn't, scan those QR codes, shoot us a message, and we can pop the link in the chat because I know you're going to want those videos. Okay, we will go ahead and start in, though, on our specific defects, okay? And I'm going to break them up for you guys in the groups that we just talked about, starting off with acyanotic. So remember, what does that mean? A without, cyanotic without oxygen. If we are acyanotic, this is kind of like a weird double negative. We are not without oxygen. So this baby's going to be pink. They are not getting blue blood out to your body. Yes, they have a left to right shunt. Excellent job, Makita. The first defect, honestly, this is probably the one you're most likely to see in the whole wide world, is a PDA, a patent ductus arteriosus. Have you guys already heard of this? I'm guessing a lot of you have. It is when that ductus arteriosus we talked about doesn't close. So let's go over here. Let's make sure you can see it. Remember that hole between the pulmonary artery and the aorta. We need that when we're in utero. And after we're born, we take our big first breath, our lungs expand, the pressure on the left goes up, and it should, in 12 to 72 hours, cause that hole to close. If it doesn't, if it remains open, it remains patent, it's a PDA. And the kicker that you've got to know is right here in red. When you listen to the baby, they will have a machine-like murmur. That is always the word that I see on final exams or the NCLEX. It is this continuous machinery-like murmur. And if you hear that, you're going to think PDA. Now, what we do for PDAs really depends on how big it is and if it's causing problems. Because if they're small, you guys, honestly, most of the time, they close on their own. It's no biggie. In preterm infants, they're much more likely to have a PDA. We might use a medication to help it close. We can use indomethacin or ibuprofen. I've personally seen ibuprofen given a little bit more. They're one and the same. You can use either of them. They help that close. Now, if it's big and causing problems, though, they might need to have surgery to boop, close that little hole. That way, we don't have blood shunting from left to right. Now, what if we want to keep that ductus arteriosus open? What if after they're born, we need that opening? That might not make sense to you yet. I'm going to circle back to it later, but I want to go ahead and plant a little seed here that we have a medication called alprostadil. Prostaglandins, PGE, these are all the same thing. It keeps the ductus arteriosus open. Alprostadil open, indomethacin or ibuprofen close. Those are your medications for PDA. And we'll circle back to why we would need alprostadil a little bit later. But let's look at our next acyanotic defect. It's an atrial septal defect. You've probably heard of an ASD. So very simply, just an opening between the atria, okay? We've got a hole between the atria, pressure's higher on the left, blood moves left to right. So again, this is acyanotic. This is a pretty common defect, and most of the time it's small, it closes on its own. We don't have to do too much for it. We do want to keep an eye on the child because remember, with a left to right shunt, we can be getting extra blood out to our lungs. They can be pulmonary over circulating. So if it's really big over time, they might not eat well. They get tired really fast, have dyspnea when they're running at soccer practice, those kind of heart failure signs when we get our wet lungs from that extra blood. We might hear a murmur with that blood shunting left to right. So again, if it's small, a lot of times they're just going to close on their own. We monitor. But if they're big and they're causing these problems over here, yeah, they need surgery to close up that hole. Now we can see the same thing in the ventricles. So ASD, we got a hole up top. VSD, we've got a hole down below. It's still left to right. It's still acyanotic, but it's more likely to start presenting with those heart failure signs around 2 to 8 weeks old. So this might be a baby that, oh, we think we hear a murmur in the newborn nursery, but you know, they look fine. They're going home. Once they're home, they're not eating very well. They're not gaining weight. They tend to be really sweaty because they're just working really hard. And then when we come in, we look at that heart, we see the VSD. They're more likely to need some management for that. Maybe they need diuretics to get some of the extra fluid off their lungs, an ACE inhibitor to lower that afterload, or a beta blocker to make their heart pump a little more efficiently. A big thing we'll focus on, though, is nutrition. Overall, I'll say this for all the heart defects, you guys, these kids are bad at eating. Their little hearts are just trying to work so hard to keep up, and they're not formed correctly. So they don't have energy left to eat. It's hard for them to breathe with that extra fluid on their lungs. So we really got to get their nutrition to get them growing. That's going to be a big nursing consideration. Now, the last acyanotic defect combines an ASD and a VSD. It's an AV canal. So we've got a giant opening, look here, between the atria and between the ventricles. So we still have left to right shunt. We're still mainly acyanotic, but this baby, yeah, they're going to have heart failure, failure to thrive, a really loud murmur. So we're definitely going to need to do those management strategies like diuresing to get the fluid off, etc. Now, these babies need a surgical repair. The AV canal can't close on its own. For the VSD, they might close on its own, likely to need surgical closure or a little patch. The ASD, most often a small one, does close on its own. But those are all the places where we can have a little hole, either between the aorta and the pulmonary artery, the ductus arteriosus, between the atria, your ASD, between the ventricle, your VSD, or both of them, your AV canal. We have a hole, blood moves left to right, acyanotic defects. You've got it. So let's check in on Slido here. I'm going to ask you about a medication because this is going to be really important later, okay? We haven't talked about why we do this yet, but if we want to keep the PDA open, what do? Do we give them acetaminophen, alprostadil, ibuprofen, or indomethacin? Mm-hmm. Okay, nice. You got it? Yes. Again, so smart, you guys. Alprostadil, remember that's prostaglandins or PGE. Those are the medications that keep the ductus arteriosus open, okay? Now, I want to check in one more Slido question here about your PDA, because I really think you're going to see this on a final, on the NCLEX. What type of murmur are you going to hear? Okay, yes. Wow, almost 100%. I am shocked. It is a machine-like murmur, a machinery-like murmur, okay? Yeah, if there's anything you're going to see on PDA, that's one you really want to know. Nice job. Okay, we're almost halfway there. Jordan, you are at the top. Oh, Jordan and Claire, you guys are tied. Wow, we got a competitive group today. I like it. I like it. Okay. Now, really quick, most of you told me you have Sure Pass. For those of you who don't feel like Sure Pass is enough, maybe this isn't your first rodeo and you have not been successful on the NCLEX yet. Maybe you graduated a long time ago and you need a lot of content refresher. We created Intense Prep for you. This is our boot camp where we go through live sessions with you for 6 weeks. Now, we named it Intense Prep because it really is intense. This is about 4 to 5 hours of studying Monday through Friday between live sessions, individualized tutor feedback, live lectures, and a 1,000-page ebook that guides you through the entire program. Is anybody here in Intense Prep? Potentially not, because you probably have your session today. Or no, it's Friday, so you probably would be free. We do live lectures Tuesday and Thursday, and your small group Monday and Wednesday. So it really does dive deep for those who need a lot more help. Okay, Salome, you're in Intense Prep right now. I hope it's going really well. It is the epitome of it's not easy, but it is worth it. It's a lot of studying. It's a lot of content. And for those of you who really need that structure, that support, like somebody cheerleading you and telling you exactly what to do the whole time, this gives you the whole package. So, yeah, price-wise, we can drop in the chat what those prices are. You can also scan that QR code or go to archerreview.com to check it out and see what options we have, what dates are coming up that potentially work for you. Okay, so hopefully you got the info you need there. Little brain break, shake it off. We've got another group of defects to talk about. We're talking about the cyanotic defects now. These are the ones that scare us a little bit, right? The baby turns blue. First one, really important one, tetralogy of Fallot. All right, has everyone heard of TET before? TET means 4, which means tetralogy has 4 defects. The first one you guys have already seen. We just looked at it. It's a big VSD right here. Then we come over to the pulmonary valve and we see that it's stenosed. It's thick and it's stiff, which makes it really hard for the right ventricle to pump blood out of the pulmonary artery. And like any other muscle, when it works really hard, it gets bigger. So the right ventricle hypertrophies. That's your third defect. VSD, pulmonary stenosis, right ventricular hypertrophy. Fourth and final defect is an overriding aorta. What do I mean by that? The aorta is usually supposed to plug into the left ventricle, yeah? So we can get blood out to the body. Well, if it overrides, it sits over, both the right and left ventricle. So it's essentially on top of this VSD. Now, this will work okay as long as the pressure on the left side stays higher. Because remember, blood goes high to low pressure, right? Left is higher normally. It pushes blood left to right, and then this aorta will pick up that left oxygenated blood. But what if the pressure on the right side gets higher than the left? What if my lungs get really expanded, high pressure, and then blood moves from right to left? That overriding aorta is going to start picking up blue blood, right? And then the baby's going to get really blue, really cyanotic, really fast. That's called a TET spell. They are hypoxic spells that occur when the right side pressure gets high. And what do babies do that cause their lungs to get big and high pressure? They scream and cry. Babies cry a lot. That's just what they do, but it makes the right-sided pressure go up. So this starts with irritability. They cry. Blue blood goes over to the left, out the aorta, and the baby is cyanotic. They turn really blue really fast. I'm talking the SpO2 is like 20, 25, 30. So we need to act quickly. The first priority intervention you absolutely have to take is to comfort and calm the baby. This hypoxic spell started with irritability. They started screaming, right-sided pressure went up, it pushed blue blood out to the body. If we calm them down, they will be pink again. Now, I know you're like, they're blue, I really want to give them oxygen. Me too. But that's not the root cause of their problem. They're not blue because of a lack of oxygen. They are blue because of a right to left shunt caused by high right-sided pressure. Calm them down, they'll be pink again. It's not wrong to give them oxygen, but it's not your priority. Other things that we can do that do help, but aren't the priority, are increase the left-sided pressure. So putting them in the knee to chest position, you guys know that's the position preferred for TET. Bigger kids with TET will naturally squat because it increases the pressure in their left side, pushes against that shunt. We also have a drug of choice in TET spells, morphine. It calms them down, it stops them from screaming, and it also relaxes their heart a little bit so that we don't have that right to left shunt. So if you get a question about priority, comfort and calm. Position, knees to chest. Medication, morphine. Those are the correct answers for TET. And it's really a common NCLEX question because you have to prioritize and intervene quickly. Now, obviously, we're not just going to like let the baby have TET spells for the rest of their life, right? They got to go and have some surgery. We're going to do a TET repair, fix them up, and they go home and have a great life. Usually they go home really, really well. Okay. Next cyanotic defect, this is something I hate to see. I would rather have TET. It's called tricuspid atresia. What does atretic mean? Remind me. If something is atretic, it's not there. It doesn't grow. So the tricuspid valve, oh, I clicked too soon. Right here, remember that should be between right atria, right ventricle. We don't have one. It doesn't form, okay? So instead of blood being able to flow from right atria to right ventricle, there is no opening there, and blood is just forced over to the left side. Again, causes a right to left shunt, so we have significant cyanosis. Okay, again, this is going to be a surgical repair. We're going to need to create an opening here so we can have normal blood flow. Tricuspid atresia is less common than TET, but it's a little more serious. I really don't like when I see a TA or a tricuspid atresia come in. So let's do a quick little check-in here. Let's ask you about TET. This is what I think you're going to see on your NCLEX. They say, what's the medication that you want to give in TET? What are you going to give them? That's right. Yep, Kusum. Yes, yes, I think you guys got it. 100%. I don't know if I have ever seen that before. I'm so happy. Morphine calms them down, relaxes that heart. Morphine is always our drug of choice in TET. Claire's back up to the leaderboard, halfway there. Now, what's your priority? Do you want to go ahead and give that morphine first? They're blue. Should we give them oxygen, calm them down, or position them knees to chest? What is our priority? First thing we do if you're alone in the room. Comfort and calm. That's right. Absolutely. I completely understand. They're blue. We want to give oxygen, but we don't do it first because remember, it doesn't call or it doesn't fix the root cause, which is them crying. Comfort and calm is the priority in TET spells. Absolutely. All right, Claire, hanging on to your lead by a second. Nice job. Nice job. And what Claire is in the lead to win, remember, is private tutoring. Okay, so these sessions are 75 bucks an hour. Claire is going to, maybe if she hangs on to her lead, win 2 of these sessions, one for her, one for a friend. And the thing about private tutoring, you guys, is that you get to pick exactly what we cover. If CHD is really hard, we can go over CHD for a whole hour. If you're like, peds, I've got it, no problem, but I'm having trouble with EKG interpretation. Kate can go over that with you. She is a cardiac expert. We can break down whatever concept you need, help you create a detailed study plan so you know exactly what to tackle every day, and it just feels less overwhelming. We have sessions available every day, morning, noon, and night. And then we also have a link where you can email us if you're like, hey, I really need a session Friday at 2 p.m. Email us. It's right on the tutor page. We can probably open something up for you, right? We've got a big team. We're all nurses who love being nurses, and we want to help you. So give that a scan. You can also email us directly. It's nclextutors@archerreview.com. Even if you don't win today, we will set you up with what you need for success. So let's finish up our defects by looking at the mixed and the obstructive. When I say something is mixed, first we talked acyanotic, baby is still pink. Then we talked cyanosis, it's blue baby. Now we've got a baby whose blood is mixing. They're going back and forth, and it's usually labeled as purple because it's got some oxygen in it, but not enough. And most of these babies are what we call ductal dependent. So you guys remember what the ductus was, right? The ductus arteriosus, it was that hole between the pulmonary artery and the aorta. They are dependent on that ductus being open. The first example of this is something called transposition of the great arteries. The great arteries are the aorta and the superior vena cava, and they're transposed or switched. So instead of the aorta hooking up to the left side, it's over here. It's on the right, transposed. Instead of the pulmonary artery hooking up to the right side, it's transposed on the left. So let's, for funsies, do a little tracing of how this blood flow is going to go. It returns to the body on the right side, goes to the right ventricle, and deoxygenated blood goes out the transposed aorta to the whole body. They're cyanotic. Now, the oxygenated blood returns to the left side from the lungs, goes to the left ventricle, and then out the transposed pulmonary artery, right back to the lungs, even though it already has oxygen. This creates 2 parallel circuits, right? Deoxygenated blood on the right side to the body, oxygenated blood on the left side to the lungs. That's not helping us. If we don't act very quickly, this baby will have profound cyanosis within an hour after birth because they need an escape hatch. We need some way for mixing of this blood. And that's why they are dependent on the ductus. They are ductal dependent. If I had a little hole right here, if my pulmonary artery connected to my aorta, my blood could mix and I could get some purple blood out to the body. This is a baby who needs alprostadil. Remember, alprostadil opens the ductus arteriosus. If we keep it open, this baby has an escape route and they can have at least some oxygen. Now, it's not going to be enough. They're still going to need more mixing. So the next thing we'll do is called a balloon atrial septostomy. This is the coolest thing I've ever seen done at the bedside. The cardiac surgeon comes in, they use a little catheter and snake a balloon up into the baby at the right atria, and then they spook it through to the left, inflate a balloon. They look at you, they're like, "Are you ready?" And then they yank that balloon through the atrial septum. So we make an ASD. We make an even bigger opening right here for blood to mix and us to get some oxygen out to the body. And we're doing all of this as a stopgap to kind of give us a little bit of time to plan for this baby's surgery. Because ultimately, they have to go to surgery and have those arteries switched. Our cardiovascular surgeons are kind of like fancy plumbers. They're going to unplug that aorta from the right, plug it back into the left where it belongs, and vice versa. Plug the pulmonary artery back over to the right ventricle. And they should go home with normal blood flow, living a normal life. This is a really challenging neonatal surgery. These kiddos come back to the unit really sick, but they usually go home with a good outcome. In comparison, if there's one defect I would never wish on anyone, it's called hypoplastic left heart syndrome. This is the first thing we're talking about where I don't have a repair to tell you about. Instead, we just have to kind of palliate it. In hypoplastic left heart syndrome, remember, hypoplastic means it's underdeveloped. The whole left side of the heart just doesn't grow well. The left atria, ventricle, aorta, they're just small and wimpy. So let's trace the blood. How's this going to go down? Blood comes back to the heart, into the right atria, right ventricle, and out to the lungs. The right side works just fine. But when it comes back to the left, oh, look how small and wimpy this side is. A teeny tiny small space makes for high pressure, right? Blood goes high to low pressure. Is blood going to want to flow through this tiny ventricle and aorta? Or is it just going to go across and go back to the right side? That's where the lower pressure option is. So it comes back to the left atria, shunts across the atrial septal defect over to the right, back out to the lungs, comes to the left, doesn't want to deal with that high pressure, goes over to the right. Okay, where's blood not going? What's our problem here? Blood's not going to the body, is it? It's going right side lungs, back to the left, whoop, too much, let's go back to the right side, lungs. If we don't do something very quickly, this baby will go into cardiogenic shock because no blood at all will be going out to their body. So again, this is a baby that immediately needs alprostadil for a little escape hatch so we can have some shunting and some mixing. Blue blood can mix with red blood right here, go through this pulmonary artery, and escape to the aorta so we can get a little bit of blood to the body. That will be your priority intervention for these mixers. If you've got TGA, if you've got a hypoplast, hopefully we've caught it on prenatal ultrasound, and there will be an experienced nurse in the delivery room to immediately start an IV on the baby and try to administer that alprostadil as quickly as possible. They're still going to be very sick. They'll probably be acidotic from the hypoxia. Their heart might not be functioning great, so they might need an inotrope to help it squeeze a little bit. And we're going to do these things to stabilize the baby while we get them ready for surgery. Now remember, we can't fix this. The whole left side of the heart over there, it just didn't grow. So there's nothing we're going to do that makes this perfect. But we can make their blood flow easier to alleviate symptoms. That's called palliation. The first step will be something called the Norwood. We do that as soon as we can. It's what allows us to turn off the alprostadil so they can actually go home. Then they'll grow a little bit, come back at about 2 months for their Glen. Go home, grow a little more, come back at about 2 years for their Fontan. Have you guys heard these names before? Norwood, Glen, Fontan. Is that something you talked about in nursing school at all? Okay, Chanel didn't. Kelsey didn't hear it. Neither did Teresa. Yeah, it seems like a lot of you did not. And this is advanced stuff. You guys don't need to be experts about these types of surgery. That's way beyond the scope of a new grad who would be taking the NCLEX. But I have seen a lot of practice questions and NCLEX questions that use these names. So for me, that's like, it's a little bit of anxiety. If you've never seen what a Norwood is, then you get a question about it. That's going to be really hard. So I just want you to know they are steps in the palliative surgery for this hypoplastic left heart syndrome. You don't even really have to memorize the timeline, but Norwood, Glen, Fontan, if you see them in the questions, now you'll know what they are. The last thing I want to say, though, is that this isn't going to last forever. It's not perfect. Their heart is going to wear out, and they possibly will be a candidate for a heart transplant later down the road. So I want to test you one more time here on Slido about that medication. If they're ductal dependent, they've got a TGA, a hypoplast, what life-saving medication do we have to give? There we go. You guys are such a good group. I'm so proud. Alprostadil, you know it. You've got it. Okay, Claire's still in the lead here. We've just got 3 questions remaining. Next one, we've got an infant with TGA. What are they going to look like? Is TGA pink or blue? Acyanotic or cyanotic? Nice, Chanel. Nice, Kusam. Roseanne, very good. That's a blue baby. That is a cyanotic defect. TGA, cyanotic. Okay, nice job. Only 2 questions to go. And really, this is the end of our presentation, looking at a couple of defects that are obstructive. These are things that stop the blood from getting out. So the first way this can happen is a valve is stenosed. In aortic stenosis, it's the aorta. It's stenosed, it's narrowed, it's stiff, which makes it really hard for the left ventricle to eject blood out to the body, especially when we're increasing our cardiac output, like exercising, running, if we're sick, if we have a fever. This is a really scary defect in the teen years because they can be like running cross country and all of a sudden, poof, they pass out. They're in VTAC. By the time we get to them, sometimes they have passed away. Sudden cardiac death is a potential with aortic stenosis. It is usually exercise induced. The other key finding is that their apical impulse, so you know when you watch their heartbeat down here, it's really pronounced. You can see it just with your eyeballs because that left ventricle, it's pumping really hard to push that blood through the narrow, stiff aortic valve. So when this is critical, we need to pop a balloon in there and whoop, blow it up. Open that aortic valve up. That's called a balloon valvuloplasty. Then we can have a surgery. It's called the Ross procedure to actually replace that valve. Don't forget, if we put a mechanical valve, anyone with mechanical stuff, they need anticoagulation. That is a key nursing consideration. Usually it's warfarin, and then we monitor their INR. The other way we can get a stenosis is on the pulmonary side. We saw this in tetralogy, right? That was one of the components for tetralogy. This is often asymptomatic until, they go run a cross-country meet and they start to get dyspnea. So again, we can put a balloon in there, blow it up, that pulmonary valvuloplasty. They can do surgery, replace that valve. Depends on how severe it is. The one I think you're going to see the most questions about is when we have a coarctation a little further down the aorta. So aortic stenosis happened here at the aortic valve. Coarctation of the aorta happens down here after the ductus arteriosus. We get this narrowing. I always think of it like a garden hose that got kinked off. So we're getting blood flow through here. We're getting blood out to this upper portion where you see these little offshoots. Those offshoots of the aorta feed the upper half of the body. Face, chest, hands, arms, blood is flowing. Then the hose get kinked off and no more blood going down that aorta. So the bottom half ends up with weak pulses, low blood pressure, pale, cool, clammy skin, versus the top half is nice and warm and pink with good pulses and a good blood pressure. This is the reason that before we send babies home, we check a pulse ox on their right hand, that's preductal, and one of their feet, postductal. If there's a difference of greater than 3 to 5%, then I'm like, why are they getting more oxygen up top and not down below? I want to look for a coarc, okay? So really what your exams are going to ask you are about these assessment findings because they want you to be able to pick up on that if you're working with a newborn. If it's critical, they need those prostaglandins. And then we need a surgery to unkink that garden hose. A lot of times they kind of cut that coarctation out, splice the aorta back together. But we got to get rid of it so the blood can flow to the lower half of the body, yeah? Okay, I want to test you 2 more times. What procedure do we do for an aortic stenosis? That aortic valve is big and stiff. We can't get blood out. What do we do? All right, nice, Chanel. Yup. Kusum. Yup. Good. Okay, this was really tricky because I put 2 procedures that we talked about. Balloon valvuloplasty is correct. For aortic stenosis, we put that balloon in the aortic valve, blow it up to open up that stenosis. Balloon atrial septostomy is for when we have that TGA, that transposition of the great arteries. It is when we put a balloon through the atrial septum and yank it to open up a hole. We create an atrial septal defect to allow for mixing before surgery. So that's a little bit more invasive, right? But they're both happening in the same area. So that's a little bit of a tricky one. Oh, and we've got a new leader with only 1 question to go. Last practice question is right here for the winner. Whoever is at the top after this gets those 2 private tutoring sessions. Ready? Everybody got it out? Okay. Assessment findings. You get a whole 45 seconds for this one. What assessment findings would lead you to think there's a coarctation? Pick all of them. Select all the findings that apply. Hey, almost there. Can't wait to see who wins it. Okay, what do we got? What do we got? Nice. The correct answers here, we've got them in green, okay? It was pale, cool feet, warm pink hands. Not a lot of blood below, lots of blood up top. Then we got the blood pressures. Brachial, that's your arm, it's high. Popliteal, that's your leg, it's low. These 2, these are switched. Radial pulses would be high, femoral pulses would be low. Those are down below, right, in your groin. So we would expect that not to be getting blood. That would be more like a +1, whereas up top, radials in your wrist, that would give you more bounding +3. Same with cap refill. A delayed greater than 3-second cap refill that would be expected down below on the feet. Up on the hands, this is what's getting all the blood. So I would think it would be more like a 1 or 2 second cap refill. Okay, who's ready to see the winner? It's Sarah. Okay. Nice job, Sarah. Shoot us an email at nplextutors@archerreview.com. We can pop that in the chat with you and let us know that you won at Archer Review free webinar, and we are going to set you up with free private tutoring for yourself and one for a nurse friend. And from here, you guys, I just want to open it up for any and all questions. We've got, 5-10 minutes left. This is a lot of content. It's very challenging stuff. So anything that you want to ask me, whether it's about Archer Review, whether it's about congenital heart defects, what we have to offer, then I am here for it. Okay. Alprostadil. Okay. Let's go here. Yeah, okay. Which defects are most important to know? Okay, great question, Becky. I truly believe that if you know the most common defects, including a PDA, a patent ductus arteriosus, your ASD and your VSD, your tetralogy of Fallot, and your hypoplas, that you will be in really good shape, okay? I know it is impossible to remember all of this stuff. In our on-demand videos in SurePass, we go through it slower in a lot more depth, but there's just so much information, only so many things that you can cram in your head. So you do want to focus on the most common. PDA, ASD, VSD, those guys are easy, you've got it. Your TET and your hypoplas, maybe your coarc too. Do we need to do monthly break exam? You don't necessarily need to do a monthly exam. Everyone's schedule is going to look a little bit different, just depending on how long you've been studying, when you graduated. We usually recommend every between 5 and 7 days going ahead and doing a readiness assessment to help you know where you stand. Remember, if you get 4 high or very highs, then you have a 99% chance of passing your NCLEX. Now, video recording, you need SurePass to access the on-demand videos, and that is already uploaded for you. You're going to go to pediatrics, and you're going to see under the topics, congenital heart defects. I go through it all in a lot of depth for you guys. So sign up for SurePass, and you will be able to watch it today if you want. Which congenital heart defect is most important? Oh, man, you're not asking me to pick just one. It's hard to say, but my gut tells me maybe tetralogy of Fallot because we see it a lot in practice. It's relatively common. It's got very specific assessment findings, and you've got to be able to prioritize those interventions, right? So it's just one that I see tested on a lot. I would certainly recommend mowing more than that, but if you make me pick one, push pinner, I think I'm going to pick tetralogy of Fallot. That's more of an opinion, though. I can't say 100%. Okay. Any other questions? This question, I'm not sure. This isn't on congenital.
All right, everyone. This is Elizabeth Diger. It looks like Morgan's internet went down, so we'll go ahead and we'll end the lecture there. Sorry for the abrupt end, but thank you so much for joining, everyone. I hope you enjoyed the Congenital Heart Defects lecture, and I hope to see you guys back here soon for one of our free webinars. You guys were a great group. Have a great rest of your day.